Good evening. My name is Jeff Parsons. For those of you who don't know me, I'm the Vice President of Risk Management and Compliance for Central Maine Healthcare. Welcome you here this evening. Thank you for attending our almost annual Risk Forum. We skipped a year by hopes, but we're back for this annual event. And we're very pleased with a very special speaker this evening. My job is real easy, and I'll do my best not to screw it up. And that is to tell you some of the logistics. The logistics for this evening are the schedule. Schedule, first of all. I will be very brief. Then Beth Skarbinski, our Risk and Claims Manager, will share some information with you regarding our system. And she will introduce Dr. Alan Verrill, who has a brief introductory statement and then comments. And then Beth will introduce our keynote speaker, Ms. Tiffany Christensen, who's our keynote speaker this evening. Following her presentation, she'll be available for questions, and then we will also just sort of seamlessly, in theory, segue into a panel discussion for any questions that are in the audience regarding presentations, regarding risk management, regarding claims, regarding patient safety, patient communication, what have you. And we will have myself, Beth Skarbinski, our speaker Tiffany, and our key defense counsel Jim Martinucci, who will be participating as well. So that's the schedule for the evening. They're also up here to my right. Ms. Christensen has books here for sale and for signing. So following the presentation, following the program, if you'd like to come up and meet Tiffany, she has books here for sale this evening. Second task of mine is to let you know that this has been approved for 3.6 hours of CME and CNE credit, 1 credit hours. Now, the little change for us this time around is we're doing it, the registration and the thank you, evaluation electronically. So following tonight's attendance, you will receive an email via SurveyMonkey. You fill that out, that will be your proof of attendance and your evaluation of the program, and then you will get the CMEs. If you don't respond to the SurveyMonkey, you won't get your CMEs or CNEs. So if you have any questions with that or any challenges, or if you don't have email for some strange, absurd reason, please contact Rhonda Tilly in the Risk Management Office, and she can set you up with the survey. So tonight's program, as was the first annual Risk Management Forum, is brought to you and underwritten by our self-insurance captive, and I'm very happy to present this forum to you again. Beth Skarbinski.
Good evening. My name is Beth Skarbinski, and I've been the Risk and Claims Manager for the last 4.5 years for Central Maine Healthcare. Over that time, I have been lucky enough to be able to... I've been able to closely evaluate our medical malpractice claims, analyze our risk events, and work with patients and their families, as well as many of you, as I have found the ability to work through and try to find some improvements that we can make in the care that we provide. A patient who is able to clearly express their complaints, their symptoms, their history, and their comprehension is an equal partner with a provider or nurse who is trying to help. A clinician who can hear and grasp the patient's story, share it with subsequent caregivers, is an invaluable part of the team responsible for guiding that patient to a timely diagnosis, appropriate treatment, and sustained follow-up. As we value each strand of the communication web that supports safe patient care, we will see less patient harm and far fewer failure to communication claims. Did you know we currently have 28 open medical malpractice claims in our system? Did you know that 54% of those claims have an element of miscommunication that we must try and defend? Did you know that from fiscal year 2008 to the first half of fiscal year 2014, we have paid out $4.767 million in indemnity that in one way or another involved communication, making the average payout of those claims equal to $280,000. which does not include illegal costs, that is direct costs to patients and their attorneys. Did you know so far in fiscal year 2014, we have had 564 events that were caused by communication failure? Did you know that 28% of our patient safety events are directly caused by communication, while even a higher percentage involve multiple factors, including other things like documentation? Did you know on a random audit that was done of informed consent tools, 88% had no alternative treatments offered on the informed consent tool, 15% had no risks documented on the informed consent tool, and only one out of all the charts that I looked at had the procedure written in lay terms that a patient could understand? Did you know that most patients that I speak to that file claims against us simply tell me, if somebody had just communicated with me, told me what went wrong, and answered my questions, we would not be sitting here right now. Patient harm continues to reach our patients, and we need your help in partnering with our patients and with each other to reduce potential and actual harm. I would like to introduce now Dr. Alan Verrill. He is the president of the medical staff and hospitalist at Bridgeton Hospital and chair of the peer review committee for Central Maine Medical Center. Dr. Verrill.
Thanks, Beth. It's a true privilege to be here with you tonight to share in this important discussion. And my work in peer review and in patient safety has taught me that much, if not most, of what we have to learn in these areas comes from the patient experience. And the patient's voice, so to speak, in that experience becomes extremely valuable. And it moves us to the next layer of patient safety. And we have a long ways to go. There have been tremendous work that's been done in patient safety areas. And yet we all know, those of us who take care of patients here, that there's much, much more work to be done. And the patient voice will be vital during that process. I'd like to share with you a little story about perhaps the most influential patient experience where I learned from in my career to date. And it happened very early in my career. It happened as an intern in my internal medicine residency. Mr. Thomas was a 66-year-old Air Force Master Sergeant. He was a well-decorated veteran. He was well admired by those that were working with him, and he was a very sick man. Bilateral kidney cancer had left him on dialysis permanently, left him without kidneys, left him with a host of medical problems, and left him as someone who was very, very familiar with my internal medicine resident colleagues and me. I was fortunate enough to admit Mr. Thomas about a week, about 3/4 of the way through my internship year. He had presented with fevers of uncertain origin, and after a long outpatient workup, which the etiology of which the fevers were coming from was not determined, he was admitted to the hospital, and we had furthered that workup while he was hospitalized with many other studies and had yet to come to a conclusion of what was causing the fevers. As the intern, I was the one that was most frequently visiting Mr. Thomas, and his family was ever by his bedside, his wife and his daughter in particular. And I know that I liked Mr. Thomas. He was an old kind of crotchety sarge, as we would say in the Air Force, but he was a good man, and I liked him. And I think he and his family began to like me, and I know that at least at that time they trusted me. And we developed this relationship over the course of time, and it was about 4 p.m. on a post-call day, and this was before residency work restriction hours, so I'd been basically up since 7 o'clock the morning before, when I was called that Mr. Thomas had had a high fever, higher than we'd seen before. He was shaking with rigors. I went up and evaluated him and knew that something new was going on, or at least something was manifesting itself, and we had done a CT scan of his chest earlier in the day. So my resident, myself, and the 4th-year medical student that were on the team went down to the radiology department and popped up the CT scanner, and back in those days you actually took films and you put them up on the board, and the series of films were there, and we reviewed it with the radiology resident and with the radiology attending. And there was a right-sided pleural effusion, for those of you who aren't clinical, that's fluid around the outside of the lung, and it was new. We had not seen that on prior chest x-rays. We presumed it was new. And by the radiology interpretation and us looking at it, it looked like it was tappable, like we could get some of that fluid out and test it. So we called the attending, and he was one of the best pulmonologists that I've ever worked with, Dr. Durdak, discussed the case, discussed what we'd seen with the radiologist, and decided upon performing the tap. And the adage in my residency back at that time is that you do not let the sun go down on a febrile pleural effusion. It needs to be tapped for diagnosis to make sure there's not infection around the lung. So I was fairly seasoned in doing those procedures at that time, and the medical student wasn't, so it was decided that the senior resident and the medical student would go do the procedure, and I went about my business to try to finish up for the day and try to get out of there at somewhat of a reasonable hour. And they went promptly to the floor and performed the procedure. About 5 o'clock, about an hour and a half later, I was called again as the intern, stating that Mr. Thomas was having a little bit more difficulty breathing and stating that his blood pressure had dropped a little bit. I asked if the procedure had been done yet and was informed that it had been done, and about that time our senior resident called me and said that they had made 2 passes, with one with a finer needle and one with a larger bore needle. Got a little bit of fluid back on the first pass, but with the larger needle, it was a dry tap. They didn't get anything done. Couldn't get any fluid. I was down on the second floor, the radiology department was on the first floor, so the senior resident went to evaluate the patient. I was down close to radiology. The post-procedure film was there, so I went down and looked at that. Again, got a radiologist to look at it with me, and the effusion around the lung was a lot larger than it was a day or two before when we had our most recent x-ray. Wasn't very hard to distinguish that probably something had been a complication of that procedure. We went up, the attending pulmonologist met us in the room with a medical student, all 4 of us at the bedside. Family was there as they ever were. Mr. Thomas was there talking to us, and we told them that we thought there had probably been a complication from the procedure, and our fear was that there was some bleeding inside the chest, and that we probably should move him to the intensive care unit for further and closer evaluation. The team of us actually took the bed, maybe within 1 tech, I believe, that was with us, but we actually wheeled the bed from the 9th floor to the elevators and down to the 2nd floor where the ICU was. The family trailing behind us, immediately behind us, we were pushing the bed together. And to this day, the next event will always live in my mind as one thing that still haunts me, is as we wheeled him literally into his ICU room, Mr. Thomas sat bolt upright in his bed. Eyes had this look about him. I can't remember if he ever said anything, but his face said everything he needed to say at that time. And he looked at us, and again, I don't remember if there were any words, but then he fell backwards in the bed, and he was out. No pulse, no blood pressure. A series of panicked evaluation went on at that point in time. Again, it was no mystery that we thought he was probably bleeding. We called for rapid blood. We were putting in type-specific blood and rapid infusers, high volume. Chest tube goes in, and again, I'm fairly new to all this type of stuff, being an intern, and the amount of blood that hit the floor was even amazing to me, as well as I think to all those around. We worked for about a good hour on Mr. Thomas over the course of that time, never got a pulse, never got a blood pressure back, and feeling quite poorly, we all decided that we had done all that we could do. And we gathered ourselves, talked a little bit, the whole team was there, along with some critical care folks that had entered into the scene, and decided it was time to go visit with the family who were in another room at that point in time. And as we walked into the patient waiting room that had been set aside for the conference that was going to take place, we walk in, filing in with the attending at first, and the rest of us filing in kind of in the pecking order of medical education, and we sat down in a room. And the look on the wife's face, and on the daughter's face in particular, and the look on our face, I think said everything that needed to be said when we walked into the room. And we sat, and Dr. Durdak sat with the family, and over the next 20 or 30 minutes explained up front with what we thought had happened, and what had happened in their ICU room, and that we thought we had been a complication from the procedure, and that we thought that her husband, her father, had died of a hemorrhage from the procedure. And that there would have to be further investigation to prove that, but it was pretty certain in our mind. Talked about an autopsy study, tried to answer any of the questions that they had at that point in time. The family had a few questions, but as you can imagine, they were in quite a deal of shock. The rest of us sat quietly, and again, one of the things that is burned into my memory is standing up after the end of this conversation, and as I walked out of the room, Mrs. Thomas looked at me, and her eyes caught one another and holding back tears the best I could with tears running down her face, all I could say is, "I'm so sorry." And I kind of shuttled myself out of the room as quickly as I could because the feeling was quite uncomfortable. And anybody who's gone through something like that, I know most of us here probably have to some degree or another, knows that feeling. As I was driving home, the medical student who had performed the tap, at about 11 o'clock that night, I guess it was, we were on a base, I had to drive back to his dorm. We were talking a little bit. He was thinking about quitting medicine at that point, and I had to tell you, I was too. And if you've gone through something like that, it's a pretty life-changing experience, I guess. You don't know how you can get up and do what you do the next day. And yet, the next day came, and I got up, and I went back to the hospital, and Anthony was there too. And we processed it, and over the next week, we put on our dress blues, and we went to a funeral, all of us together. And we sat there, and went by the family again, and gave our condolences. We did the things to learn from an experience like that. We didn't call them an RCA back in those days. I guess we didn't have that catchphrase, but whatever we did, we learned a lot. We learned that there was an aberrant artery that was in the outside part of his lung that had been transected completely, and that he basically had an arterial bleed. Something very unusual, but was what happened, and the pathology slides from the autopsy showed that. We learned that a CT scan image of a pleural effusion is not the same as what the tried and true method is of a decubus film. You do a regular x-ray lying the person down, and what was a tappable effusion from a radiology standpoint of view was less so from a blind tap, which we didn't do ultrasound in those days, medical standpoint of view. And I can name a few other things that we learned. But in this particular case, I have to admit that I learned the most about a month later when, after, I can't say I ever forgot Mr. Thomas, and certainly not by that time, but things had kind of gone back into my own routine, and I was in the dreaded internal medicine clinic. And I went in the afternoon, and I opened the door to a new patient, and in that room was Mrs. Thomas. And I don't know if she could read my face very well, but my jaw probably hit the floor because she was the last person in the world that I expected to be in my clinic at that point. We talked, obviously, and mentioned her husband some at that point. Didn't talk a lot about her husband, but it's enough that we kind of processed where she was and how she was doing, and she asked me a little bit about that as well. But went through that uncomfortable 45 minutes or an hour with her, and she was my patient for the next 3 years or thereabouts. And she saw me regularly. She had her own set of healthcare problems. We talked about her husband every now and then, but again, in a pretty superficial way. And it wasn't until the last time I saw Mrs. Thomas at the end of my residency when I was going to say goodbye and head off to another base to do the payback for the Air Force that I was obligated to. When she sat down and said, "Dr. Farrell, you can put away your chart and everything, because I'm not really here today to talk about my healthcare. I'm here to say goodbye. I'm here to tell you a few things." And I sat down, I put away the chart, and I probably had the best patient education experience that I've ever had. And we use patient education usually thinking that we're talking to the patient. And she educated me that day, probably better than any lecture that I've had, any one lecture in healthcare. And she said to me, "You know, I was angry after that happened to my husband. I know he was sick, but I know he died in a way that he probably didn't have to die. And I didn't know who to be angry at, but I was angry. But I knew that those people in that room cared about my husband. I'd been with you guys long enough to know that nobody did anything purposefully, but you cared about my husband." And I had to process that somehow. So in my anger and figuring out what next step to do, I needed a new doctor. And you know what? I thought she remembered that look of our eyes both meeting each other and walking out of that room. And she says, "I don't know where the rest of those folks are going with this, but I know there was one person in that room who's still here, who's still learning, and what I want to know is that made a difference, because I saw a difference in his eye that night, but I want to know if that stays with him. I want to know if that impacts somebody as they go forward in this business that we do." And she says, "You know, I've gotten to know you pretty well over the course of this time," and goes, "I think it has affected you. I'm not sure about that, but I know it's affected me," she said. She goes, "because I'm a changed person. I'm no longer angry. I've gotten some peace about what happened to my husband, and part of this has been that process of me processing it. So, Dr. Farrell, I don't know if you've been changed, but I've been changed, and I want to thank you for that." And she's crying, and I guess I was starting to probably get that way too, as I am right now. I looked at her, and I had to say, you know, I hadn't thought about it that way, but I can tell you now I'm changed. I think I'll never forget your husband, and I haven't. I don't think I ever would anyways, but I can guarantee after this process I won't. And I'll try to somehow take what I learned by his care from a technical standpoint of view, and I don't know if I said it quite so eloquently, or at least it sounds, but somehow take that and add it to what you're teaching me today. And I hope I never forget what it feels like to some degree to be here with you right now, both in the good part about what it means to share in this with you, but also the sad part about what we do sometimes leave people where we wouldn't want them to be. So tonight, with that story, there's a table in the back of the room tonight that's draped in a black tablecloth. I don't know if anybody's recognized that or stopped there and paid a little attention to that. But we learn from our patients in many ways, and a lot of times if we're lucky, we can hear with their voice, like I heard from Mrs. Thomas that day. But many times we don't have patients where we have the voice present any longer. Mr. Thomas's voice wasn't present, I learned through his wife. And at that table represents patients who have a voice to share with us, but it's not their own individual voice anymore, it's their legacy of what they left behind and the care that we deliver to them. And if I've left you a little uncomfortable with this, I'm not apologetic, because I think sometimes what motivates us to change is when we personalize and feel a little bit of that pain from time to time, not to wear it any longer than we need to say that we want to do better if we get a chance to do it again next time, but just enough discomfort to push us in the right direction so that we're not satisfied with another person being injured when we could have prevented it. So please, tonight, with their honor and their legacy for folks that we've done our best to take care of, but we could have done better, spend a moment at that table, I ask you, and think a little bit about your Mr. Thomas or your Mrs. Thomas, and let's see if we can do a better job as we go forward in all that we do. So thank you.
Now I'd like to introduce our keynote speaker, Tiffany Christensen. Since 2007, Tiffany has presented over 1,000 workshops and lectures to providers, patients, and families. In addition to being a national speaker, Tiffany is the author of Sick Girl Speaks, and we are the change, transforming the healthcare experience through partnership. Tiffany combines her extensive experience as a patient with her training as a Team Steps Master Trainer, Certified Respecting Choices Advanced Care Planning Instructor, and Appeals Certified Trainee. Currently, Tiffany is a professional patient advocate at Duke University Hospital, working primarily in the area of oncology. She continues to travel throughout the United States to present her workshops and lectures on patient family-centered care, patient safety, advocacy, advanced care planning, donation, pediatric illness, and life in the deathbed. Tiffany is currently the project lead for Duke Health System's Patient Family Advisory Council Expansion Program. Please help me in welcoming Tiffany as she presents Partnering with Patients, a Bedside View of Patient Safety.
Am I going to have a conflicting mic situation here, do you know? I don't want to make anybody's eardrums burst open. That was a beautiful story. Thank you for sharing that, if I can start with that. Thank you all for letting me be here tonight. We've got a lot of things to talk about, so let me give you a brief overview of what we're going to be going through together. I'm going to be talking a little bit about what I now call a hybrid patient experience. Somebody called me that recently. I have an extensive background as a patient, which I will talk about, but now that I work in healthcare, now I kind of get to see both sides of the bed, and so now I'm starting to think of myself more as a hybrid, if that makes any sense. So I'm going to be talking a little bit about that perspective, looking at patient and family-centered care from a couple of different angles, and talking about team steps and partnership. And for those of you who are less familiar with team steps, we'll talk about what that means as well. So what we all know, of course, is that the landscape of our healthcare culture is shifting, right? So we have over here on your left the olden days version of what healthcare sometimes looked like to patients and families. So we have a physician who's rounding on his patient, and he says to his patient, when we want your opinion, we'll give it to you, right? So that's sort of the old-fashioned version of what patients and families fear when they come into our healthcare systems that they will lose all control of their life, their body, their future, right? And then you have the opposite end of the spectrum now. As we have our healthcare culture shifting and we're talking about patient and family-centered care, now there's some fear among providers about loss of control in a slightly different way. So we have a cartoon that sort of exemplifies that. You've got a nurse who's hanging an IV, and the patient's wife says to the nurse, remember, only gravy in his drip, he's on Atkins, right? So this idea that somehow, now that we're talking about patient and family-centered care, that our patients and families are going to now be dictating their care, which is something that is not necessarily what we all hope for as we try to perfect our practices, right? So my hope is that as we talk through the rest of this evening, that we're going to look at new ways to bridge these two very wide ends of a spectrum. So we all know that the culture change is due to a lot of reasons. One of those reasons, of course, is Dr. Google, right? That we have our patients and families walking through our doors now with a much different level of access to information, and that really shifts the dynamics. We also have competitive markets. So, for example, I'm from North Carolina. As was mentioned, I work at Duke Hospital. You might know that right down the street from Duke Hospital is another major health system called UNC Chapel Hill. Now, when you're driving down in my area, driving down the highway, it's pretty hard to miss all of our hospital billboards everywhere, right? So we have one billboard that says, cancer care as it should be. What exactly does that mean, right? That's a beautiful marketing term, but it also sets us our expectations to an unknown and possibly unachievable level. Would you agree with me? Because if I am a cancer patient and I walk in through those doors saying, this is my cancer care as it should be, my definition of that is going to be very different than your definition of that. So how can we possibly meet everybody's expectations? And yet, marketing is simply a part of our society. So this is something that is really affecting the way our patients and families walk through our doors. And then, of course, we have, as I've already alluded to, we have some questions now. As the culture shifts, we have questions about what are the appropriate boundaries. If we are now incorporating patients and families into the healthcare team, where do we draw our lines? And we're going to be talking a little bit more about that as we go through this tonight. So we're asked to look at all of these new complex dynamics in healthcare. And in addition, we're asked to do all of this, take care of our patients with less money. Is anybody getting a little sad? I don't mean to make you sad. What I mean is to sort of set the stage for how complicated and how very challenging this landscape is for us right now, but also to present to you as we go through the rest of this evening some thoughts and some food for thought to take home with you about how to address all of these things.